We're really honoured to have you here chatting to us today. Will you tell us a little bit about yourself and what you do?
So it's really nice to see you again. My name is Alex. I am a physiotherapist. I work in Athens in my private clinic. Recently, I opened a second one closer to my house. And mainly in the last 10 years, I focus on patients who have, how can I say, pain problems. Well, you cannot find the patient without pain problems, right? When they come to the practice, they talk about their problems with their aches and their pains. I've been focusing on what we call long-term pain in the last 10, 15 years. So I was trying to be more effective in these kind of people, not just trying to apply things, not to apply manual therapy, to apply needling therapy, which I consider myself, quite well educated on this stuff. I'm one of the first people in Greece, physiotherapists, who have been using and teaching about needling therapy. But mostly I focus on the context of pain, on how do people deal with it, how do people understand about it, how clinicians understand about it, what it is about. And I'm trying to help people who are trying to cope with it. So I see patients at least 3 to 4 days a week, and I usually teach on weekends. So that's my my schedule. And I hope we have an interesting chat today.
Yes, definitely. We're looking forward to it. So start us off with, what is central sensitization?
It's a word, it's a meaning that many have heard about, but not very many people, I think, not even clinicians are clear about what it is. So for some people, central sensitization is a synonym. That means it means the same as chronic pain, which is not true. For some other people, it's some sort of brain activity that contributes to the experience of pain. Some similarities, but also not true. So if we would say in one word, what is central sensitization, we would say that it's just a function of the nervous system. And it is a function that has been developed, as almost everything in mammals and humans, as a mechanism to protect the system, to protect the body. So we can talk a lot about it, but it's just a normal central nervous system mechanism. That's all. And all we need to know is why and how it works.
Okay, so it's not, when you say a function, so it's not a dysfunction, it is a function. So it's a normal thing to happen.
It is. It's
okay.
Actually, many people don't realize it, but for example, if people search for central sensitization in Google Scholar, or to read articles or books or nice databases who are reliable on reading this kind of stuff, he will see that it is a mechanism that works as a dysfunction of pain. It is a dysfunction or an amplification of pain mechanism. But actually, central sensitization is there to make a lot of noise on the system when something not good for the system is happening. For example, when we get sunburned and we cannot touch our back, so you see my face, this is a reaction to the sunlight we have in Athens right now, 38 degrees. So when we get sensitized by the sun after we stay out there and we cannot touch ourselves, we have sensitivity and pain on the red part, but we get sensitivity on the white part, the ones that are not affected by sunlight. So this sensitivity, this easiness to produce pain, is a normal mechanism of the central nervous system to make us aware that what we did was wrong for the skin. So better not do it again. It is the same mechanism that will react, for example, if we get stung by a wasp or, a nasty bug that will produce, all the reactions that we know, the autonomic reactions, the reactions on the immune system. If you read about it, you will see that central sensitization phenomena or central sensitization syndrome is something that you can find talking about the complex reaction of these systems when something that is considered, not good for the body happens.
Okay, so how then does that, Alex, link with chronic pain? Is that something then that this central sensitization just continues, rather than short term, it continues long term, to cause a problem?
Okay, I will try to make it to talk about it in the simplest way, but not to be simplistic. Okay, simple but as accurate as possible. Now, first we have to realize where the central sensitization it happens inside the central nervous system, but it is not happening in the brain. It is happening in the spinal cord and especially in the dorsal horns of the spinal cord, which, if we think about it, again, it is part of the gray matter of the brain. But the area where this type of sensitization is happening is actually in the dorsal horn. So at the area where the information from the periphery is getting inside the system, so the first synapse, as we all clinicians know, the information of something happened to my hand, I burned my hand, for example, the first synapse is inside the dorsal horns. Right there, the information goes upwards through the mechanisms that we all know, the ascending mechanisms. The system decides to make this information more important than it probably actually is. So if the information is a bug stung my limb, my hand, this is very serious. So central sensitization works perfectly. You have a lot of pain. You have the whole system reacting. But if central sensitization is starting when the information from the system is, I lifted something really heavy, and now all my hand hurts. This is something that shouldn't happen. An injury did not happen at my hand. And normal information got inside the system. I lifted something heavy, but the system considered it very important. So a lot of pain would arise from this incident.
If we go to the sort of the clinic environment, what sort of patient is presenting to you where you are making that diagnosis or evaluation of a central sensitization, something that has healed, actively healed, but actually now the system is maybe overreacting to less of a stress? What sort of patient do you get in your clinic that is presenting like that?
Well, I can give you examples of pathologies like the one that I told you, but what helps a lot is first the characteristics of the pain, and especially two words that we know. One is if the patient is showing allodinic behavior. It is producing allodynia. Allodynia is when a stimulus that should not produce pain, it produces pain. So when I'm doing this to my hand, if it produces pain, then this area is in central sensitization mode.
Yes.
Hyperalgesia also, secondary hyperalgesia. So someone is super sensitive and you press here, and what you expect is from someone to feel the pressure. Okay, not so bad. But if a person screams from the pain, This is secondary hyperalgesia, and secondary hyperalgesia is also a characteristic of central sensitization. So in real patients, one of my best examples is a patient who has an ankle sprain. When you have a second-degree ankle sprain, you expect in the second week, almost everybody in the third week to be fully recovered, load the foot, have no pain, no problem. So after 20 days of taking care of the healing mechanism and begin to load properly the area, you expect someone to get back to his activities the fourth week and play sports, okay, after a month. Now, some people complain about continuous sensitivity in the area and continuous pain after 5, 6 weeks, 2 months. They're not like, aching, but they say that it's not what it was before. If I give too much load, if I walk more than 15 minutes, 20 minutes, the pain comes back. And it is the pain I was feeling in the beginning when I had my injury. Now, these are all indications that the system that is producing pain, the nociceptive system, as it is called, is malfunctioning. There is altered nociception. That's the word we use when we want to describe what is central sensitization. So it is altered nociception, incorrect nociception that is being produced in the periphery. And this is what makes us think, that's what makes me think that, okay, chronic pain, long-term pain, after a normal healing has happened, maybe I should look into the central sensitization scenario.
Okay, and so how would you, because I think I've had over the years lots of examples myself of that, and central sensitization has not necessarily been in my head. I've always thought, well, I'm missing something. There must be something there that that I can find, that I can treat. How do you explain to your patient that they have a central sensitization or a misfiring, if you like, of the nervous system when they're saying to you, I can really feel pain? How do you tell them that without them saying, without sort of implying that it's all in their head or in their mind? What do you say?
That's the trickiest part, because one of the bad things that we had from all these years, these last 20 years that we had this great book, I told you in the beginning, the Explain Pain book, was that too many therapists being affected by what the phenomena of pain are doing to the beliefs of the patient. We had this tendency for years to tell to the people, it's in your brain, the problem. Now the patient doesn't like that, because you're implying that there's something wrong with his ability to understand what's going on. So I know that everywhere it's not accepted. In my country, it's offensive to say something like that. People questioning their sanity, probably.
Yes.
What you feel is not what actually happens. Again, this is why it is interesting to do this talk, because when a patient is feeling pain, we have to accept it. Now, if we don't accept the patient is feeling pain, then we are not capable of helping him. So you tell the patient, I totally understand that you have pain. So the second question the patient has is, all right, then why am I in pain? Is this because it is not healed properly, my injury? And I think this is the actual point where you can step on it and tell the correct words. So I hope the sound is not very bad, because my practice is in the center of Athens, and we have ambulances going up and down. Very sorry about that.
That's fine. We can hear you fine, Alex.
Excellent. Thank you. Now, so the patient asks, so I am not healed properly? And there you start and say, no. Healing always finishes in the correct way, because that's how the system works. Then why am I in pain? Is something broken? Is I have something more serious? And then these two questions, again, are easily to overcome. You have made all the proper checkings that you didn't break something else, and there's nothing wrong with other diseases with you. So why am I in pain? And this is where we tell them, because your system is oversensitized. Not you, but your system is more easy to produce symptoms. And this is something they're interested in listening, realizing what is going on.
Okay. Okay, so hopefully, again, I'm thinking of different patients I've seen over the years. So once you've done your thorough examinations and you are happy that there is nothing else going on that's sinister that you've missed, and you've got these patients where they are reacting sometimes sort of what you would consider abnormally to very small stimuli, then you can make that sort of assessment that they have a central sensitization. The system is reacting abnormally. What is your treatment? So what do you actually do to help them?
Well, we know, so far, we know that the treatment against pain being produced by not correct signaling from the nociceptive system, this type of pain, in the last 5 years, we call it nociplastic pain. So it's the pain that is being produced inside the central nervous system. This type of pain, what we know so far is that we can help it go away. We can desensitize the system by try and give every day or every other day an amount of information on the area or on the system from the area that is in pain of changed, of altered, how can I say it, more healthy, more proper information about how the area is functioning. Because mainly the system will react in a desensitizing way when my back hurts, when my foot hurts 2 months after an injury. It is reacting like that because everything that comes from this area, the load that it's come from this area, the system thinks it's wrong. If I start loading it in a different manner, then the system will consider the different manner maybe a chance to start looking it differently. How, if I could say it, I'm not sure if it's very clear of what I'm saying. So usually sensitized areas are deloaded areas. They are areas where we have not been able to use them properly. They are areas where the patient has been careful in using them. So first, we get into motion, into moving. Moving makes the system recalibrate the information it is getting. It's like a computer pressing the reset button. So this is the desensitization mechanism. And this is the normal way that the system would do that if no other help was around. The second way of desensitization is from the therapist putting his hands on the patient, because actually the system has mechanisms to help block the incorrect information, the nociplastic information, and giving information that the system considers it healthier, more normal, and more easy to understand. So when we put our hands on the patient, we know that, you know that, I know that, the patient feels better because the system considers the specialized passive movement as a way to overcome the pathway of pain as it stays like that for a long period of time.
And so in terms of how long you might see that, let's say you have got a patient that you have made some symptom modification, then you've introduced the loading. Is there an end in sight, or are these patients just managed? Are you managing these patients for the rest of their lives, or
No. Sorry that I interrupted you. You want me to give you time frames from
yeah, so I'm only in terms of again, because some patients, they want to come and then they want to go. But if you've got someone who's had pain for a very long period of time, is that something you can completely get rid of and then come to an end and then part ways? Or is that something where this patient needs little top-ups for the rest of their life, whatever that may be?
Well, I try to avoid this. It's my personal philosophy. I tell them, my patients, when we finish, that, listen, I hope you will not need me again. That's what I tell them. And for those who feel, a bit worried about losing the patients, I tell them this brings back more patients. So I try to desensitize the patient from the need to see me all the time. But the patient needs that I'm here for him. I'm not advising for every now and then come back and see me, and if you feel pain, come straight away and we will fix it. I tell my patients that if symptoms come back, you come and we discuss and see what went wrong and what we should change in order for you to produce the pain. I try not to make the patient guilty of anything, but I try to make them understand that it's their responsibility too, because it is really weird for me. People are coming to me and telling me, okay, we did 6 sessions. I'm great. Thank you very much, Alex. So this is not going to come back again. And I said, how can I answer that? But we fixed it, didn't we? And I tell them, well, listen, you get hungry every day, don't you? And the patient said, yes, of course. Well, in order not to get hungry, you have to eat every day. I told you and I showed you that your back is painful because every day you do things that are bad for your back and you do not exercise. If you stop doing the correct things, it is probable that you're going to have symptoms. And many patients don't like that. They consider the body as a machine that you fix, and then it should operate optimally for the rest of their lives.
Yeah, even as they do things that are not helpful for the body, don't eat as well, or like you say, don't move or whatever, or don't exercise, they still expect their body to still move optimally, like you say, but there's all these other factors that have an impact on that, isn't there?
It is. That's why my opinion is always educating them, trying them to realize what's going on. And when they come back and they tell you, listen, I haven't been doing much, can you please help me again? I'll say, yes, of course I will. But realize that this is going to be again and again the same scenario. And some people do not understand that the more times they get into the pain circle, the easiest the next episode of pain is going to become. Again, this is very well studied. So pain is not something that we should be proud of or living inside. Pain is something that we should deal with. We should not avoid. We should deal with it, and we should learn from it. If we don't learn from pain, pain becomes our friend and never goes away. And we know this when we talk about really serious pain situations, chronic pain situations, like chronic regional pain syndrome, CRPS, like fibromyalgia, conditions that central sensitization gets, I'm really sorry about the bad word, it's just in a way to say the severity, it gets malignant. It cannot be reset as easy as it can be reset after a badly loaded ankle sprain.
Yes. Okay. Is there anything just to sort of wrap this up a little
Yeah.
bit, is there any closing thoughts, Alex, that you can sort of anything you wanted to add to you know, our members about what we've talked about today? Anything that we've missed out, or anything you feel that they can go away and look at, or any last messages?
Well, as you were asking this, I tried to realize what would be nice and interesting to hear. And I will tell you what I've been hearing from people that were very important teachers of me 25 years ago, where I was a student or starting my career, and realizing now how important this information was. Now, the teachers would say, listen, learn the mechanisms of your work. Don't just be really good in reproducing things you learn, but also know how this thing works to the patient. This adds up a lot on the effect of your work. And it sounded right, like a really good, you know, advice. But now, after a few years, I realized this is called metacognition. So it's a thing. It's a thing that is being taught in students who learn about, you know, behavioral sciences. So being able to understand why and how your intervention works makes you more effective. So I would say to all clinicians, if you haven't thought about it, please focus on how you become effective. Don't just look yourself in the mirror and say, wow, I'm great today. I did really good techniques that Jamie told me or learned me, but just try to find out why do these things work. So that would be my contribution to the end of the talk.
Absolutely, yeah. I think that's a great one to end on, really. So,
thank you.
Just thank you so much, Alex, for your time and your knowledge. I know I've learnt loads.
Oh, fascinating.
And I probably need to go and buy that book now. That's another book I need to buy. So, we really appreciate you giving up your time this afternoon. So, thank you very much.
Thank you, Alex, for joining us.
Thank you very much to everyone who would be interested in our talk, and thank you for the invitation.
You're very welcome.